Hey team, so today we're going to talk about the aorta exam for ultrasound. We're looking at the abdominal aorta as it courses from the time it enters to the time it bifurcates right at the umbilicus. So the objectives are to describe the clinical issue of abdominal aortic pathology, describe anatomy of the abdominal vasculature, imaging techniques, and pathology. So we perform the aorta ultrasound as an emergent or urgent ultrasound evaluation as we are resuscitating a patient with a potential AAA or ruptured AAA. It's accurate, it's rapid, it's non-invasive, and it can be performed at the bedside, making it a great imaging modality. What's the anatomy of the aorta as it passes into your abdominal cavity and then bifurcates? So the abdominal aorta is a tubular structure that enters at T12 and then bifurcates at the umbilicus. It's typically a little left of midline, but it can roam over to the right. The abdominal aorta lies just anterior to the vertebral body, which is a huge landmark that we look for on ultrasound. It's posterior to other vascular structures. It can be eccentric and is often covered by gastric or bowel gas, sometimes obscuring your ability to see it, but there are techniques for working around the gastric or bowel gas. So branches of the abdominal aorta are going to be first your celiac, splenic, and liver arterial supply. Then you have your SMA, which supplies your proximal bowel, and then your renal arteries, which can, if they're involved, can cause morbidity with any repair. Then you have your lumbar arteries, which can be the cause of endo leaks with stents, and the IMA, which can also cause leaks with stents. So here we're looking at the view of the abdominal aorta as it courses into the abdominal cavity and looking at branches and its relation to the IVC. When doing this, you can use either a phased array or a curvilinear probe to evaluate the abdominal aorta, but just look at the difference between the two of these. My preference is obviously the curvilinear probe, which you might have noticed with a lot of exams. It gives a much better view, and if you look at the image on the right, we can see the abdominal aorta, we can see the vertebral body with shadowing beneath it, giving you that nice view or Mickey Mouse view that you want to see. So in order to scan, we want to scan both the long axis of the abdominal aorta and the short axis of the abdominal aorta, looking for any changes in the vessel lumen, any dilation, anything in the vessel itself. The transverse view seen here is the most accurate. We're looking at the aorta, we're looking at the IVC seen in blue, and then the spine with shadowing. Making sure you have correct depth is important. So misidentification of more superficial vessels does occur. You have to make sure that you're seeing the spine. Misidentification of other abdominal structures also occurs. So look at your depth setting, look at your patient. Does the depth make sense with the patient? Make sure that you have enough depth to make sure you are seeing the spine, the shadowing, and the abdominal aorta. You always want to measure in 2 dimensions, your anterior, posterior, and then across, transverse, or right to left, if you will. If you have an ectatic aorta, this can be a super challenging patient. In the longitudinal axis, we want to look and we want to see the celiac vessel and the SMA branching off. We want to make sure that we are measuring perpendicular to the aorta in the long axis. This is going to be a critical view in order to detect a saccular aneurysm. It also may help in determining if it's an ectatic aorta. It's a challenge to show the bifurcation into the iliacs on the longitudinal aspect, but make sure that you're scanning down to the bifurcation in the long axis. You can use an oblique view in order to visualize your iliac vessels. So what are some scanning approaches? So for scanning approaches, here are some maneuvers that will help you get a better image of the abdominal aorta. You want to first apply gentle, constant pressure. This is going to help dispel any bowel gas or gastric air that might be obscuring your image. You can also modify the angle of the transducer, and you can use the liver or parasplenic window in order to get a better view. Remember that the aorta is closest to the left flank in the coronal view. So if we're getting fancy, you can use the coronal or parasplenic window in the case of pretty bad gas. Look from the coronal left flank, the distal large vessel at the inferior aspect of the screen. That's going to be your abdominal aorta. But really, most of us use the right on top of the abdomen, the anterior to posterior approach. We want to look at the long axis, we want to look at the short axis, we want to see the vertebral body and its shadow. When starting off looking at the proximal long axis, make sure that you're seeing the celiac and the SMA vessels as they branch off of the aorta and measure. In our transverse axis, on the left side of the screen, we're able to see the labeled aorta, then the celiac trunk, and the celiac trunk as it branches into the splenic artery and common hepatic artery. We can see it with colored Doppler applied as well. It almost looks like a seagull, if you will. Now here's just a schematic of how everything lines up when we're looking at the long axis of the abdominal aorta. We're seeing the celiac and the SMA here, and just distal to that we have the branches of the renal arteries. And when we overlay the IVC, we have the celiac, the SMA, and you'll note that the left renal vein runs underneath the SMA, so right between the SMA and the aorta. We want to make sure that we compare the aorta and IVC, because if someone has a fairly plump or plethoric IVC, it can be difficult to tell them apart. We want to make sure you can look in transverse, make sure that you're seeing the aorta on the right side of the screen, the IVC on the left side of the screen. We'll also note that the aorta has pulsations, whereas the IVC has more of a triphasic movement that's affected by respirations. We can also look in long axis. In the long axis, we can follow the IVC as it enters the right atrium and look for triphasic respiratory variation. So now that we've scanned the proximal aorta, we've scanned in transverse and longitudinally, because when you're doing an ultrasound exam of the aorta, you want to make sure that you get proximal, transverse, proximal, sagittal views, and then you want to scan down to the aorta to view the distal aorta. So some tips with the distal aorta. Here we are again going to measure our transverse and our sagittal aorta distally, and then we want to see it branch into the iliacs, so see that bifurcation. So remember, the distal aorta, it tapers. It'll become more anterior in the abdomen, so you may need to change your depth setting, and then it's going to bifurcate into the iliac arteries. So as you're doing your aorta ultrasound exam, you want to look proximal aorta, transverse, sagittal, follow the aorta down, measure distal aorta, transverse and sagittal, then visualize the bifurcation of the abdominal aorta. The next question is, how do we measure the abdominal aorta? So it's really critical here that we measure from outer wall to outer wall, not inner wall to inner wall. So from outside wall to outside wall. We want to measure in two planes at every level. If we do find a AAA, it's great to define its relationship to the renal vessels and the iliac arteries. So you can see in this view here, we have the vertebral body and shadowing, and we have our measurements from outer wall to outer wall and outer wall to outer wall. So note the enlarged aorta here. It'd be pretty easy to miss if you did not notice the clot on the posterior aspect and the intimal flap. So this one's measured correctly, but you can see right here outlined like a crescent moon of an intramural thrombus or clot. So make sure that you're getting those measurements as well. You want to evaluate the lumen. You want to make sure that the lumen itself is anechoic or black with minimal echogenicity inside the wall circumferentially. You really want to make sure that you do not see any linear structures across the lumen, and identify those, look for those in both the transverse and sagittal planes. Other things that we look for in the lumen of the abdominal aorta include atheromas, clots, any intimal flaps, or foreign bodies like stents. So you can see this one right here. I would have done this with a curvilinear probe, but this one has a stent in place. We can see here, we just saw this a few minutes ago, but this aorta has an intraluminal thrombus. So this is a medium level echogenicity within the lumen. It's usually located along the anterior and lateral walls. Here, this one's located around the posterior and lateral walls. If you do come across an abdominal aortic aneurysm, this is an abnormal dilation of the abdominal aorta. You do not have any distal tapering with these. And what are some of the diseases that can weaken your abdominal aorta and lead to ultimately an abdominal aortic aneurysm or AAA? So some things that we think for are high blood pressure, syphilis, cystic medial necrosis. So the danger in weakening the walls with this high pressure is that you'll ultimately have wall failure. So some of the etiologies of a AAA would be atherosclerosis, syphilis, cystic medial necrosis, Marfan syndrome, trauma, or persistent hypertension. We define a AAA as a diameter greater than 3 centimeters or a diameter 1.5 times the diameter of the proximal uninvolved segment. And remember, there are two kinds of aneurysms. There are fusiform aneurysms and there are saccular aneurysms. Some common aortic emergencies include an aneurysm where you have an abnormal dilation of the abdominal aorta, and a dissection where you have a ripping or tearing of the intimal wall leading to an intimal flap and just dissecting through that intimal wall. So remember that your aorta normal vascular wall has 3 layers: the intima, the media, and the adventitia. Aneurysm can include any part of the wall. Dissection, it's usually the intima that's displaced, and it can also occur with aneurysm formation. Aneurysms, fusiform aneurysms, are the most common type of AAA. These usually project anteriorly and to the left. We can often see thrombus along the anterior wall of the AAA. That's where you're having that turbulent flow, if you remember back to your pathophysiology classes. Another aneurysm shape is the saccular aneurysm. This one is less common. So this is attached to the vessel lumen by a mouth. Thrombus tends to partially or completely fill the aneurysm. So here is an example of a saccular aneurysm. So you want to make sure that you're measuring the proximal unaffected portion and then the affected portion. Now, so where are AAAs located? 90% of your AAAs are going to be below the renal arteries. In 40%, there'll be extension into the iliac arteries. So you need to evaluate the iliac arteries as well when you're evaluating the bifurcation. So make sure that you have to evaluate the distal aorta. This is a critical step in performing a AAA scan. When it comes to AAAs, the risk of rupture is directly related to the diameter. So expansion normally proceeds at a rate of 0.2 to 0.4 centimeters per year. If a AAA is greater than 5 centimeters, you have an increased risk of rupture. However, an AAA may rupture at any size. So just because it's 4.5 centimeters doesn't mean it's safe. It means it needs to be followed. Rupture of a AAA usually results in a rapidly expanding retroperitoneal hematoma. The mortality for this is 50%. This can cause hypovolemic shock and death. Pre-rupture into the peritoneal cavity has a mortality of greater than 90%. So if identified on ultrasound, these patients are sick, they have a high mortality, and they need emergent care. So AAAs are found in approximately 2% of the population. High-risk groups include those with coronary artery disease, hypertension, those who are older after the 5th, 6th decade of life, and much more common in men. So what's the management of a non-rupturing AAA? If it's less than or equal to 5 centimeters, we expect a typical growth rate of 0.5 centimeters per year. 1 year risk of rupture at 5 centimeters or less is less than 5%. However, people can rupture their AAA at any size. So with this, typically serial ultrasound exams are performed every 6 months, and these patients are followed. If your AAA is greater than 5 centimeters, the risk of rupture just about exceeds the operative mortality of elective repair. So if I have a patient with a 5 centimeter AAA in the emergency department, I'm getting a surgical consult. As far as managing rupturing AAAs, this is a little bit advanced for the undergraduate medical education, but you want judicious fluid resuscitation. You can allow these patients to remain a little bit hypotensive, so permissive hypotension. Blood products. They will need blood products and more blood products. You want to support their airway, but you want to avoid RSI. This may precipitate arrest in these patients. Emergency surgical consultation is indicated if the patient is unstable, and the surgeons can discuss open repair versus endovascular stabilization and stenting. So the mortality and the emergent aspects surrounding the management of a rupturing AAA has led us to create a code rupture algorithm, which puts all specialties on high alert. An abdominal aortic dissection is a little bit of a different beast when compared to a AAA. It's a different pathophysiologic process. It may be simultaneous. A patient can certainly have a AAA plus dissection. When we're doing the ultrasound, we want to look for a linear echogenic line through the lumen or thrombosis of a false lumen. Doppler may help detect different flow states. So here we're seeing aortic dissection in the short axis on the left side of the screen. You can see a linear echogenic band through the middle of the aorta, and then we're seeing in long axis. In the long axis view, you want to make sure that you're fanning through the entire aorta in the long axis from right to left to make sure that you are seeing the linear echogenic band in that view. All right, so that's it about the abdominal aorta. We have talked about its location, its branches, relevant anatomy, and pathology, including a AAA and dissection, 2 of our acute aortic emergencies that we want to make sure we are evaluating for. Please email me if you have any questions, and happy scanning.